Okay, so we're going to move on to injuries to muscles and bones. This is probably like the last chapter of our trauma unit. So this is just a little bit more focused on like it's kind of like soft tissues and just like different types of fractures and sprains and strains. And there's a lot of stuff in this chapter, and they just kind of touch on a little bit of all these different things. So there's quite a few injury patterns we'll talk about. So just some basic anatomy and physiology. Hopefully you guys have not brain dumped this yet from this semester, but just know there's three types of muscles. And if I say involuntary, that's known as smooth, and that's also kind of like our organs. Voluntary is known as skeletal. So and then of course cardiac is found only in the heart. It has those intercalated discs that help the heart beat. So just kind of know that. And there you go. That's just a little picture of it. All right. So mechanism of injury, that's what MOI means. It just means like what happened. So a person broke their arm. Okay, how did they break their arm? Was it a twisting force? Was it direct, indirect? That kind of thing. And there's a lot you can learn from the mechanism of injury. So pay attention to that. And there's a big difference between different mechanisms, right? So just it's always okay to ask a few extra questions about what was he doing when this happened. All right, so fractured. Broken bone, probably some of you broken bone. I've broken my collarbone before. Usually takes some significant force. Closed fracture, that means the bone is under the skin. Open fracture, the skin is open. It doesn't necessarily mean the bone's poking out or anything, but it just means that the skin is open. And both result in bleeding at the fracture site. Okay, dislocations. You probably at least know a friend or something who's like dislocated their shoulder. It's pretty painful, but not necessarily dangerous. Now there's a spectrum now. So like elbow dislocations, that's a pretty complicated joint, and like even at my level, paramedic level, we really don't mess around with that a whole lot. However, shoulder dislocation. I mean, sometimes people can put their own shoulder back in, right? If they dislocate it a lot, they like know a trick and they can pop it in themselves. So there's kind of a spectrum as dislocations. Usually very painful, and they will need to go to a hospital or some sort of orthopedic clinic or something to get that. So just write this down. Word sprains and strains. I guarantee there's questions in the test about it. So a sprain is ligaments and a strain is tendon generally. So try to remember this. Strain is a T for tendon. Okay, so strain equals tendon muscle. Sprain is ligaments, and you could argue that's actually worse because it's bone on bone, and so it's pretty painful. So sprain has the word pain in it, pain, ligaments. I don't know, or you could just remember it like a normal person, but whatever you want to do. So know the difference between sprains and strains. Okay, they're going to be painful. These are extremity injuries, so they're going to be pretty painful. Might have an open wound, lots of swelling and discoloration. That's very normal. Patient's inability or unwillingness to move. That's a good red flag. If they're like self-splinting, holding their own arm, and then they refuse to move it. Okay, that means it must be pretty hurt if they don't even want to move it. So, and then of course deformities or angulations. That's not good. Just more pain. So when you're looking at that, you can find an open wound, and the reason we care about that is there might be some more blood loss with that, and of course the risk of infection. Deformity, swelling, bruising. These things swell up pretty big, and pretty quickly too. Within under an hour, you'll start to see some pretty massive swelling if we're looking at like ankles and knees and stuff. So we don't have X-ray vision, and there's not a lot we can do for these. We can splint it, take it to the hospital, right? But the one thing that we can do that is very, very important is checking the pulse motor sensation. That's why that last thing is bold. That means if I have a broken arm, I'm going to go down the wrist. I'm going to feel for a pulse, right? If I have that, so if the patient has a pulse, he can feel everything. He knows what finger I'm grabbing. He can move his hand. Okay, that's good. Now, if I go to check that pulse on his wrist and I don't feel one, that means that arm, the broken arm, so maybe that bone fractured in such a way that it cut off the artery, or who knows, cut the artery wide open. So the one very important thing that we have to do like at the ambulance level is we have to check that distal circulation. We need to know that extremity has good blood flow. So cover the wounds with a dry sterile dressing, bandages, we talked about that. Usually, just providing pressure, direct pressure, will stop most bleeding, but if you need to, you can go to a tourniquet. You can apply a cold pack. That actually helps reduce swelling quite a bit, at least in that first 24 hours. And then splint, we got to splint it. So the reason we're splinting it is if there are some broken bone ends in there, they're not going to be rubbing on themselves, right? If we splint it, kind of lock it in place, we reduce that movement. But if we don't splint it, those bone ends can do a lot of damage to the surrounding tissue. Helps control bleeding. It decreases additional damage, and it also prevents like the bone from poking out of the skin. All right, so remove clothing all the way. We can pad the splint. You can remove the clothing and then put it on the splint, but we need to see what's going on. So remove the clothing, cut it off with scissors if you need to. Um, check that PMS, check that distal circulation so you know you have it. Cover the wounds, apply splints. I'll send you guys some videos. Unfortunately, we can't really do splinting in class just because we're not in class, but I can send you some videos of different splinting stuff. So don't move the patient before splinting unless there's immediate danger, but for the most part, you want to splint it before you start moving around a lot. Immobilize the joint above and below the injury site and then pad the splint. So think about that. Just remember above and below, above and below. So anytime I'm splinting something, I need to remember to make sure that I've immobilized above and below. So if I have like some sort of elbow fracture or radius ulna or something, yeah, I can put it in a sling, but I also gonna want to put a swath which goes around the entire arm and kind of locks it in. So yeah, I lock the elbow down, but that shoulder can still move everywhere, and we want to reduce that. Okay, so just remember above and below. These are the different types of splints that are out there. SAM splint, you'll see a picture of that in a second. That's probably the most common one. That one's probably the most widely accepted splint. So, but there's other. I've seen cardboard splints and balsa wood, and you can make a splint out of popsicle sticks. Like it doesn't matter, right? It's something that's hard that you can secure a limb to. So there you go, SAM splint. They're very foldable and moldable. You can do any number of things with these. You can put lots of creases in it and actually make it be rigid. Soft splints is kind of like the air splints. Disadvantage is, well, it's zippers and gets has dirt and all that kind of stuff that a SAM splint you don't have to worry about that. It can get popped and then there goes your whole splint. And temperature and changes in altitude can also decrease the effectiveness of the splint. So air splints are good, but you just need to keep an eye on some of those other concerns. All right, traction splint. This is traction, so it's pulling something, right? And so this is meant for a fractured femur, only a fractured femur, and not like a mid-shaft femur, okay? So it's a splint that goes on the leg, and it pulls the ankle away from everything else in it, and that pulls those femur bone ends apart, and it reduces that pain. So traction splints are awesome, but only for femur fracture. All right, and shoulder girdle injuries, that's what I said, sling and swath, right? We just want to make sure we immobilize and above low. Shoulder dislocation, all of these are kind of like, all right, stabilize in place and go to the hospital. So what they're saying there is shoulder dislocation, you can put it in a sling and all that, but elbow injuries is a little bit more complicated, and it's like, yeah, just tape a bunch of pillows to it if you need to and take it to the hospital. There's like a bursa sac in there, there's nerves and arteries and all sorts of stuff in there, and if we're not careful, we can do a lot of damage manipulating an elbow injury. So basically, splint it as it lies, make sure there's distal PMS, and take it to the hospital. There you go. Just we're not messing around with elbow injuries. All right, forearm injuries. These ones are easy. You can do air splints, cardboard splints, SAM splint. I mean, whatever you want to do. And I'll just have to send you guys some videos of how to do splinting for that injury. So yeah, I'll send you guys videos of all this. So this is kind of the for hand, wrist, finger issues. Bulky splints are good. If there's an amputated part for whatever reason, a finger got blown off or something. These days, surgeons can do a lot of good stuff, and they can actually reattach quite a bit. So always try to find an amputated part if you can. Keep it like in a sealed plastic bag. Keep it cool, but don't put it on ice because it'll literally get frostbite. But we want to keep it cool and take it to the hospital. Maybe they can reattach it. And then with like for fingers and stuff, popsicle sticks. Popsicle sticks and tape is awesome. All right, pelvic fracture. These ones are scary because, as you can imagine, there's lots of junk going on inside that pelvis, right? There's lots of organs and lots of blood flow and lots of scary stuff happening. So be careful with these pelvic fractures. You can see in that picture there, they're kind of pressing on it, and you can test it for stability and kind of see if it sounds solid, or if you press on it and the patient, reports pain or something. That's good. But other than that, we don't want to be manipulating these pelvic injuries a lot because of all that important stuff that's in there. So usually we just wrap it up with like a pelvic binder, which is almost like a big towel kind of thing that wraps around the whole pelvis, and you make it tight and it just kind of brings everything together. Hip dislocations, well, hip injuries are kind of like that. Dislocations are a little bit different. There maybe is not so much concern of bleeding and things, but our bodies, we're meant to move biomechanically with that ball and socket joint in our hip. And if that's dislocated, well, now we can't walk anymore. And so it's still a pretty big concern. And this is, I know people joke about it. Oh, he's old, he fell and broke a hip, ha ha ha, like you can break a hip. Well, people do that. People do fall in elderly age, and they do have like osteoporosis, they have bone issues, and they fracture their hips and they die. So I know everyone kind of jokes about it, but hip fractures actually kill a lot of people. So use blankets, pillows, whatever you want to do. Put them on the backboard. Just that'll help, stabilize it and immobilize the whole situation. All right, thigh injuries. As we talked about earlier, that traction splint, femur, big old bone. So if you've broken a femur, that's a lot of force was applied. So there's probably a lot of damage there. So traction splint, control bleeding if you need to, and take to the hospital. All right, knee injuries, same idea. It's kind of like the knee is like the elbow of the leg, right? The same idea. So try to splint it in the position you found it. Check that distal PMS, take to the hospital. If there's some deformities, just do your best. A lot of this stuff, as long as you don't violate the principles of splinting, you can kind of splint however you want. All right, so like I said, I will post videos of. Okay, leg injuries. That's like your like tib fib and stuff. You basically make a big old boot, a boot out of the splints. But I'll send you videos of all that. Yep, I'll send you videos of that. Okay, moving on to head and spinal cord injuries. This is a little bit different, just because it's a little more complicated than like a broken arm. But so we have the cerebral spinal fluid, that is this fluid that's hanging around in our brain, and it kind of cushions the brain. But if it leaks out, then we know we're in trouble. So the cerebral spinal fluid really should stay in there, right? And so if there's any sort of clear fluid or CSF coming out of the ears or nose or something, we have a serious problem. All right, so closed head injuries, open head injuries, right? So closed, there's bleeding and swelling within the skull, puts a lot of pressure on the brain, and that can kill someone right there. Just that the swelling, as you can imagine, our bones don't swell, right? And so we really don't have a lot of room in our cranium for that expansion. So even a little bit of increase in pressure can actually start causing a lot of problems. And in fact, for people who have really bad cerebral edema, like really bad head injuries, they'll actually take the skull away. They'll actually surgically remove like half the skull, and they'll put it like in the body, like in the abdomen, so it doesn't like die. And then that way, when the body's swelling and the brain's doing its thing, there's a lot more room now for that swelling to take place. And that's unfortunately kind of what you have to do. There's no way around it. So there's nothing we can do at our level. I mean, I worked on a patient who had been shot right in the forehead with a gun, and he was leaking brain out of his forehead. And to me, that just seemed like, wow, aren't we going to do something about it? But the doctor's like, well, no, because what are we going to do? Cover that up? Where's the swelling going to go? He's got a gunshot wound, lots of swelling. The pressure, it's got to let itself out. And if that's how it's doing it, that's probably the best we got. So closed head injuries are scary for that reason, because the swelling can get real bad. There you go, just saying this is called a coup, counter coup or something. So it's basically that whiplash going back and forth, can have some spinal issues at the same time. So for head injuries, you've probably seen somebody, or maybe yourself, you have gotten a concussion. So they're going to be confused, unusual behavior, unconscious, nausea, vomiting, blood from ears, decreased consciousness, unequal pupils, all of those things. If you hear about it like a head injury and you can check this patient out and any of these things are going on, you got to be pretty worried, because that means it's serious and they need some pretty serious interventions right now. Now, head injury may produce raccoon eyes, battle signs. I would write these down, memorize these, whatever. It's not too. There you go. Raccoon eyes. Hey, easy to remember because it looks kind of like a raccoon, right? And then battle signs is bruising behind the ear. Okay, and those are both skull fractures. So on the test or whatever, if I'm saying raccoon eyes, battle signs, equals head fracture or skull fracture, okay? Immobilize the head best you can. And the reason we're careful about these is if someone took some sort of impact to the skull to like break the skull, well, there's probably a lot of forces applied, right? Well, your neck is not that far away from your head, so we're really worried about spinal issues for head injuries. All right. Now, determine whether blood or CSF is seeping from a wound. Now, you don't need to do this. I may not put this on the test or anything, but there's something called the halo test where basically I take some of that blood that's coming out of the ears, let's say, and I put it on a dressing, like a 2x2 gauze pad, and I just leave it for 5 minutes. And the CSF is actually will separate from the blood. So you'll see like where you initially put the blood, and then you'll see this kind of little yellow ring that's around the blood, and that's the CSF. So that's kind of a test that they can do. And that's, like I said before, head injuries are bad, but if you got a head injury with leaking CSF, it's a lot more serious. Okay, so spine, we talked about this, right? It's that head impact can go down to the neck. The little morbid rhyme is C 3 through 5 keeps the diaphragm alive. So cervical spine, 3 through 5 keeps the diaphragm alive. If you sever those, the diaphragm will not work, and there you go. You can't breathe without the diaphragm. Yeah, so just saying, when in doubt, put these guys on the backboard, stuff like that. I agree with that. I don't have X-ray vision. I don't know exactly what happened. I can't really tell. So you have to err on the side of caution, especially for spinal stuff, because if you do it wrong, that person might end up paralyzed, and we obviously don't want that. So when in doubt, be pretty careful. Okay, so this is just some of the signs and symptoms to look for in that spinal cord injury. They might have weakness, numbness, paralysis, loss of movement beneath the level of the injury. And just another random thing you can do is I call it sharp, dull discrimination. So let's like you take a pen or something and you have them look away, and you take the pen and you can use like the sharp side of it and go, does this feel sharp or dull? Okay, then flip it over and use the end of the pen, which is dull, and then do it again and say, okay, was this sharp or dull? And that's a test that a lot of people don't necessarily do. They go, oh, okay, he can feel this. It's like, we're good. He can feel it. He knows I'm touching him. All right, we're good. Well, yeah, but hold on a second. If he can feel it, but he can't tell if it's sharp or dull, okay, we have a problem. So that's kind of an extra step you can take, and make sense. Okay, that's we're talking about loss of sensation of movement, all that stuff. Full C-spine, cervical collar, backboard, whole thing. Maintain their airway, jaw thrust best you can. Give oxygen. You do want to assess pulse sensation in all extremities, right? Because you don't exactly know what the situation is with the spine. You don't know where the injury is exactly. So check PMS in all extremities just to make sure we still got blood flow everywhere we need it. Okay, I already mentioned that. All right, one of the last things we're going to talk about, injuries of the chest. So there's like our ribs, right? Now these are tough because they're very, very painful. Just the rib fractures are very, very painful. And in fact, some people actually acquire pneumonia in the hospital because, our lungs, and we cough stuff up, right? We clear our lungs out. Well, they're not going to be breathing they'll breathe with very shallow, small breaths, because big breaths pushes up again and forces those ribs to kind of move, and that's going to be painful. So some of these people don't actually breathe a whole lot. I mean, they survive, but they can acquire pneumonia super easy because their lungs are not really working to their full capacity. All right, so try and figure out whether if it's, now here's the thing, bruised or broken, you're not really gonna know. You're not really gonna know what, like, the difference just by looking at it. So pat it, like nice bulky dressing, pillow, something like that. You want to just prevent excess movement. Now, flail chest is if 3 or more ribs are broken in at least 2 places. And what they mean there is it's like its own little island. So imagine you got your chest wall and there's 3 ribs that are all fractured in the same place, and now you got this little island of bone now that's completely unattached. We call that a flail chest. Okay, there you go. So it's saying it's just one little area, 3 ribs are broken, and that's a lot harder to manage. It's a lot worse than just a typical rib fracture. All right, there you go. Bulky dressing. Okay, so penetrating chest wounds. These ones are scary because, mentioned previously in that shock lecture, there's going to be a hole in that chest. Air can go inside that, and then it's lung versus air. Air is going to win every time. The lung is going to try to expand and push against that air, but it's not going to be able to. So then that lung is going to get crushed. And so just so you can see in that picture there, if you have air, blood can do this too. But if you have air or blood in the chest cavity, just like that, it actually crushes the lung. And that needs surgical intervention immediately. It's kind of a weird design flaw in us, but if we have air in our chest where it's not supposed to be, we can die from that. So basically, that's why I put the occlusive dressing in all caps, or I mean bolded. The best thing here is to prevent air from going in, right? So occlusive dressing, you can buy store-bought occlusive dressings that are made for this and they're super fancy adhesive, or tape and plastic. Who cares? The idea is keep air from entering the chest. So however you want to do that, use plastic, use whatever you want to do, just don't let air in. Now at my level, you might actually have to put a needle in, needle decompression. You take a 14-gauge needle and you poke into the chest cavity and the air escapes out of the needle. And that buys you some time, but that's not a definitive treatment. Those patients generally will have to go to the OR and get chest tubes and like the whole thing. So these patients can decompensate pretty quickly though. So if you have an open chest wound and you think there's air in the chest, I mean, that's like potentially like a life flight kind of thing. Like that can get really bad because there's nothing you can do about it. Other than trying to decompress it with a needle, I mean, really, that this person's in a lot of trouble. They need a surgeon. Now, if a knife or other object is impaled in the chest, do not remove it. We want to stabilize it best as possible because we don't know that impalement. It might have be closed off an artery or something, and now we're going to remove it, and now the artery is going to bleed, and boom, patient dies. So if there's any big objects inside the chest, we want to stabilize that, tape it, do whatever we got to do. Let the surgeon handle that on his end. So that was your quick down and dirty lecture on musculoskeletal injuries. If you want to, I have other lectures for my EMT class that go into a little greater detail about some of those things, but up to you. So with that, this should be our last chapter until the exam.